So you want to know what's the truth about prostate cancer? Well, in this video, you'll learn all about what's true and what's not true in the prostate cancer arena. Welcome to HEALTHdrum. I'm Dr. Bert Vorstman, a urological surgeon and former researcher, and this channel is all about routine medical conditions, self-care, and digital health, so you can be informed and in control of your medical needs. If this is your first time on the channel and you like to get fact-based healthcare information, please hit the subscribe button for me. By the way, HEALTHdrum is for educational and informational purposes only and not a substitute for professional medical advice. The links to the disclaimer and the material in this video are in the description below. Okay, so let's get into it and start sorting fact from fiction. So what's the truth about prostate cancer? Well, although this question seems rather counterintuitive, there are many reasons for great concern. So these facts about healthcare truthfulness give great cause for concern. Most healthcare is financially driven. Most published medical research is false. Only about 11% of medical treatments are of known benefit. 23% of medical treatments may be of benefit, and some 66% are of dubious or unknown benefit. Furthermore, you will often see or hear the term standard of care. This term does not mean that a test or treatment has been scientifically proven to be safe or effective. Often this term is meaningless, just that the test or treatment is in common practice. Again, the references to the material and the blog that is also called What's the Truth About Prostate Cancer are listed in the description below. It's strongly recommended that you read these references. So who's responsible for healthcare and medical misinformation? Here's a list of some of the reasons why a lot of healthcare information is simply recycled misinformation. Due to strongly held beliefs by physicians, a lack of oversight by healthcare regulatory agencies, the business engine of healthcare and financial conflicts of interest, healthcare foundations and support groups, and social media algorithms. Much, if not all of this information cannot withstand the challenge. Where's the irrefutable and reproducible data supporting this recommendation? So the prostate cancer industry broadcasts many claims about the benefits of testing and treatment for prostate cancer. Let's check some of these claims. Here's a list of some of the many claims published by the prostate cancer industry. Get screened early, get screened annually, get screened before it's too late, early detection allows early treatment, and early detection saves lives. And there are endless other claims about the benefits of PSA testing and radical treatments. But are they fact or are they fiction? What is the irrefutable and reproducible evidence supporting these claims? As well, there are many claims about early warning signs for prostate cancer. But are these fact or are these fiction? So these symptoms of dribbling, weak flow, interrupted urinary flow, blood in the urine or in the ejaculate, and erectile dysfunction are commonly claimed to be early warning signs of prostate cancer. This is not true because urinary and sexual symptoms are simply part of prostate enlargement and aging and not due to a small cancer that may be detected. So where exactly is the prostate located? The prostate is located immediately below the bladder and in front of the rectum. It can be easily examined with a finger in the rectum to detect any abnormalities of the prostate. This test came about because it was discovered that some prostate cancers can feel hard. But what does the prostate do? What is the purpose of the prostate? So the prostate gland has several functions. It produces much of the fluid for semen. It helps contract to assist with ejaculation during orgasm. It produces the PSA to liquefy the ejaculate so sperms can travel up the vagina and uterus. It produces the enzyme 5-alpha reductase to regulate testosterone production, and the prostate helps with urinary control. So the prostate gland has a very important function, but it can still be affected by diseases and cancers. However, most prostate cancers are outlived. So prostate cancers are not all equal or the same, and most are outlived. The majority of these cancers are sluggish growing, taking some 40 years to reach 1 centimeter in size from the time of mutation. The Gleason 6 is labeled as a cancer, but is a false cancer as it fails to behave as a cancer. Only about 10 to 15% of prostate cancers are high-grade and potentially deadly aggressive cancers. Also, some 80 to 90% of prostate cancers are multifocal, meaning that there are 2 or more areas of cancer in the prostate. The reason for prostate cancer being multifocal is because of the phenomenon of field effects. This is where the prostate tissue has been sensitized to become malignant by some unknown agent at some point in the future. And because prostate cancers are not all the same or equal, Dr. Gleason devised a grading and scoring system to try and estimate the aggressiveness or lack of aggressiveness of various prostate cancers. So are some men at greater risk for developing aggressive or high-grade prostate cancers? There are some risk groups that are more susceptible to aggressive, high-grade, high-risk prostate cancers. Older men, those with a family history of prostate cancer, black men, and those with certain inherited conditions, as well lifestyle choices may also put you at risk from developing aggressive prostate cancer, such as eating charred meat, highly processed foods, and other lifestyle choices. Some 10 to 15% of prostate cancers are aggressive, high-grade, or high-risk, and potentially deadly. So what are the tests that are routinely recommended to screen for prostate cancer? So these are the screening tests commonly recommended for prostate cancer. However, as we proceed, you will see that both the prostate exam and PSA, or prostate-specific antigen blood test, are highly unreliable. The non-contrast MRI study of the prostate is the most reliable screening and detection tool for significant or aggressive prostate cancer. Again, the urology community will call these tests standard of care, but the term standard of care does not mean that the tests or treatments have been scientifically proven to be safe or effective. Let's look at each prostate cancer screening test in detail and see how trustworthy they really are. So what's the truth about the prostate exam or digital rectal examination for screening for prostate cancer? So the prostate exam or digital rectal exam reliability depends on the examiner. It's associated with significant errors of interpretation. It is also associated with inter-observer errors, or the fact that judgments as to what was felt differs between doctors. The lesion, nodule, or growth needs to be at least 1 centimeter in size and near the surface of the prostate before it can be detected or felt. Examination is no more reliable than a coin toss, and there's no evidence that the prostate exam saves significant numbers of lives. In other words, the prostate exam is not a useful test to screen for prostate cancer. What about the PSA blood test? Is that a useful screening test for prostate cancer? So most PSAs are raised or elevated because the prostate is enlarged because of BPH or benign prostatic hypertrophy or enlargement. The specific term in the Prostate-Specific Antigen label is a barefaced lie because it is not specific for the prostate or for prostate cancer. The so-called limits of 0 to 4 being normal are a fraud and misleading because they are made up. The PSA is associated with about a 78% false positive rate, and some high-grade aggressive prostate cancers may produce little or no PSA and be missed on screening. In fact, the PSA test is so unreliable that it fails to meet the criteria necessary for the screening test to be useful. So what about the non-contrast MRI? Is that reliable for detecting aggressive prostate cancers? So the non-contrast MRI, especially in the right hands, is able to evaluate the whole of the prostate gland. It's the best screening tool to detect aggressive prostate cancer and ignore low-risk cancer. The non-contrast study avoids gadolinium and possible contrast allergies. Also, it can avoid risky and unreliable random prostate needle biopsies. However, MRIs do require experience since cancers can be overlooked. So in summary, the non-contrast screening MRI is a much better screening and detection tool than the prostate exam and the PSA blood test. But this study is also not foolproof. So although these screening tests are not foolproof, do they save significant numbers of lives? Sadly, urologists' own studies have concluded that PSA testing fails to save significant numbers of lives. As well, there's no scientific evidence that the prostate exam or that the non-contrast MRI saves significant numbers of lives. Yet, despite these well-known facts, urologists and their prostate cancer awareness surrogates continue to recommend prostate cancer screening using these tests, and abnormalities detected with these unreliable tests invariably leads patients to risky, unreliable prostate needle biopsies. So how is the prostate biopsy done? So the prostate biopsy is done by sticking a needle into the prostate and getting a tiny amount of tissue. In descending order of reliability and starting with the least reliable is the transrectal biopsy. Commonly 12 needle cores are taken in the standard 12-core ultrasound-guided needle biopsy. This results in about 0.1% of the prostate being sampled and means that the doctor is clueless about what's going on in the 99.9% rest of the prostate. Slightly less risky, but also associated with a huge sampling error, is the transperineal biopsy, and a little more reliable than these biopsies is the fusion biopsy that combines an MRI study with an ultrasound study. However, the most reliable prostate biopsy technique is the MRI-guided biopsy. The reliability of these needle biopsies is a big concern, particularly because of the small amount of tissue sampled and the fact that most prostate cancers are multifocal, meaning that the cancers are commonly in several parts of the prostate. So is the prostate biopsy risky? Is it associated with complications? So the prostate needle biopsy is associated with significant risks such as pain, infection, and sepsis. Sometimes it requires hospitalization, and sometimes it causes death. Also, there's rectal bleeding, urinary bleeding, and blood in the ejaculate. The blood in the ejaculate can last for several weeks. As well, there can be erectile dysfunction. What about your biopsy result or pathological diagnosis? Is that always reliable? So there are reliability concerns with your biopsy results or pathological diagnosis. Did you get an accurate diagnosis? Cancers need to be a certain size before they can be reliably targeted, and then there are concerns whether or not the correct lesion was biopsied. The Gleason classification system is complex and dependent upon the knowledge and judgment of the pathologist. Errors of interpretation are possible. Studies have shown that grade misclassifications and disagreements between pathologists are common. Different pathologists can deliver an alternative diagnosis for the same biopsy. Even the same pathologist reading the same slides at another time may offer a different diagnosis. Now, because of these concerns, a second opinion on your biopsy result is highly recommended. What about X-rays or imaging studies to see if the cancer has spread? Are they reliable? So the X-rays or imaging studies done for staging or the process to see if the cancer is still confined to the prostate or not are not exactly reliable either. CT scans and bone scans are insensitive for detecting small amounts of cancer spread. On the other hand, the whole body MRI is useful for detecting bony spread, and the PSMA PET or CT scans are useful for detecting lymph node spread. These tests may be impacted by false positives and false negatives, and the study interpretation by overreads and underreads, and some aggressive cancers may have already spread to the bone marrow before being detectable on MRI. So PSA-based screening, biopsies, and imaging for prostate cancer are relatively unreliable. What about prostate cancer treatments? So this is a rather revealing screenshot, and again, all the references to this material are in the description below. So in general, there's no irrefutable and reproducible evidence that prostate cancer treatments bring about life extension or save significant numbers of lives, whether at 12 years, 15 years, or 20 years. In fact, no treatment had similar survival rates to those that had surgery or radiation, but these folks that had no treatment were left without all the complications routinely seen after surgery or radiation. And sadly, although there's a lack of evidence for cure, the business of prostate cancer and their various support groups and foundations are still recommending the current prostate cancer narrative and to go for testing and treatment. But what about the other treatment options for prostate cancer? Are they reliable? Are they curative? So here's a screenshot of the list of treatment options for localized prostate cancer. This includes active surveillance or watchful waiting for those with low-risk, non-aggressive cancers, surgery, both open and robotic, radiation therapy, which also includes brachytherapy or seeds, proton beam, and several focal therapy options using cryoablation or freezing, HIFU or high-intensity focused ultrasound, laser, and photodynamic treatments. However, there's no scientific evidence for life extension or cure with any treatment options for prostate cancer. Physicians are well aware of this fact that neither PSA testing or prostate cancer treatments save significant numbers of lives. Yet, they continue to recommend PSA testing and robotic prostate cancer surgery. But how come, and what's the reason some clinical studies claim benefits of prostate cancer treatment? How can this be? So every so often, clinical studies are produced that claim a semblance of cure. However, these studies are invariably flawed because the studies are not based on sound scientific principles. Commonly, the studies include participants with the Gleason 6, which is a false or pseudo-cancer. They also include subjects with various cancer aggressiveness, various Gleason grades, scores, and tumor volumes. And some participants are arbitrarily treated with testosterone suppression. All of these issues nullify or cancel the conclusions of these studies. These studies have been designed to offer a semblance of benefit or cure. So these radical prostate cancer treatments are not curative. What about their complications? So radical prostate cancer treatments are associated with probably more complications than any other procedure. General complications such as bleeding, deaths within 30 days, thrombosis, emboli, rectal tears, and depression. There are other injuries specific to robotic use such as trocar and positioning injuries. And whether open or robotic, surgery is associated with a long list of potential penile injuries such as loss of libido, manhood, and erections, lack of ejaculation or ejaculating urine, penile pain, or pain on orgasm. shortened penis, testicular pain, and infertility. With respect to the bladder injuries, urinary leakage or incontinence is high on the list, as well as bladder neck scarring and urethral strictures, which often lead to urinary tract infections and bladder stones. As well, up to 40% or so of subjects will have a positive margin or residual cancer after surgery, and after 10 years or so, many patients will also have a biochemical recurrence or a rising PSA, meaning that there are some cancer cells somewhere in the body that have yet to be detected. The tragedy here is that radical treatments don't extend life, and most of these complications caused by radical treatments require additional treatments. Residual cancer or positive margins are usually treated with radiation, while biochemical recurrences are commonly treated with monitoring and/or androgen deprivation therapy, which is also associated with its own list of side effects. In reality, radical prostate cancer treatment fails to save significant numbers of lives and is associated with a long list of potential complications. In other words, it's a public health disaster. What about prostate cancer awareness and active surveillance programs? Do they save significant numbers of lives? So prostate cancer awareness and Blue September are heavily marketed by the prostate cancer industry and their surrogates. But we've already seen that there's a total lack of scientific evidence supporting the prostate cancer screening and treatment paradigm because there's no scientific evidence for saving significant numbers of lives. As well, testing and treatment are associated with significant health dangers. Yet, the business of prostate cancer markets and broadcasts the benefits of prostate cancer awareness by claiming that if you understood it better, then you'd be able to make better informed decisions, and that awareness allows for early detection and enhanced treatment options, better survival, and treatment with less aggressive treatment options. Again, all of these sound great, but there's no scientific evidence that prostate cancer awareness programs save significant numbers of lives. Instead, they only lead countless unwitting men to great harm and health dangers. What about the active surveillance program for low-risk, non-aggressive cancers? Is that reliable? Does that save significant numbers of lives? So there's been a big push for active surveillance for low-risk prostate cancer, claiming all sorts of benefits, such as delays potentially harmful treatments, allows timely detection of significant cancer, allows intervention with less aggressive treatments, avoids major complications, and that there may be improved quality of life. However, there's no scientific evidence that active surveillance saves significant numbers of lives, and for many, it only increases the anxiety, risks, costs, and time wasting. So how can some men on active surveillance for their low-risk prostate cancer suddenly wind up with an aggressive metastatic prostate cancer? How does that happen? So there are some reasons why men can be on active surveillance for low-risk prostate cancer and suddenly be diagnosed with an aggressive metastatic prostate cancer. These are some of the reasons. The prostate exam is highly unreliable. PSA testing is highly unreliable, as some aggressive cancers produce little or no PSA and can go undetected. The MRI may fail to detect a significant cancer because some aggressive cancers have already spread before they can be detected. As well, the needle biopsy may have missed the target, and a new higher grade of prostate cancer may have developed because 80 to 90% of prostate cancers are multifocal and impacted by field effects. That means that the prostate has been sensitized to develop more cancers over time and possibly more aggressive cancers. The problem here is that these particular aggressive cancers may not produce PSA, and they may have already spread to the bone marrow before being detectable on MRI. So the whole concept of detection limits is important. Detection limits for prostate cancer screening and diagnostic tests refer to the lowest level or smallest amount of cancer that a test can reliably detect. Different tests have different sensitivities and specificities, and their detection limits vary based on the technology used. However, nothing is foolproof, perfect, or 100% reliable. So what's the truth about the current prostate cancer narrative? So despite this damning evidence against the prostate cancer narrative, PSA-based screening and radical prostate cancer treatments continue on because those in the business of prostate cancer have chosen to continue to recycle misinformation and recommend risky and ineffective care, an abuse that fails to keep patients from harm and injustice and only underscores a shocking degree of intellectual dishonesty, especially because the cure is worse than the disease. And this disaster is made a lot worse because of the indirect adverse effects on the wife or partner of the patient. We simply need better tests and treatments for aggressive prostate cancer. The current prostate cancer narrative lacks supporting, irrefutable, and reproducible data for safety and benefits. So in addition to all the references in the description below, the following 2 books are valuable sources of information. So these 2 books expose everything that's wrong with the prostate cancer story. The Rise and Fall of the Prostate Cancer Scam by Dr. Anthony Horan, a urologist, and the other book, The Great Prostate Hoax by my colleague Ron Piana and Richard Ablin. The current tests and treatments for localized prostate cancer have created simply a public health disaster. Remember, every test and treatment recommendation should be able to withstand the challenge. Where's the irrefutable and reproducible data supporting that recommendation? Again, check out the references in the description below. So let's recap. In this video, What's the Truth About Prostate Cancer? You learned that most prostate cancers are outlived. Prostate cancer screening fails to save significant numbers of lives. Prostate cancer treatments fail to save significant numbers of lives, and the treatments are associated with a long list of potential complications. To learn more about routine medical conditions, self-care, and digital health, check out these other videos.